Hello, a very good afternoon to all of you. It gives me great pleasure to welcome Dr. Shrikant Solav. We've known him for a long time. Almost the entire city knows him, the state knows. He needs no introduction. Still, I would like to introduce him to all of you. He is a practicing consultant in nuclear medicine in Pune for the past 22 years. He has done his MD in medicine from Bhopal University and DRM in nuclear medicine from Mumbai University. He runs the PET-CT Center, SPECT Labs at Pune. He organized and conducted the first PET-CT in Pune in 2007. He has about 40 articles to his credit in publications. And today we have invited him to address mainly the postgraduate students to talk about PET-CT in rheumatic disorders. As you all know, in many of the rheumatic diseases now we have to resort to a PET-CT for diagnosis and further management. So do feel free to ask questions. Sir has come specially here today to teach all of you. Okay, so please, over to you. Thank you.
Actually, I was unaware that there is a post MD teaching program of rheumatology in Bharati, and I was actually pleasantly surprised that you have an intense course. It reminds me of my teacher who was appearing for his DM in cardiology from GB Pune. You know, in his final year exams, what he was asked, DM and cardiology exam, his external examiner came and he said, Dr. Saab, I know that you know cardiology. Please tell me why this dyspnea is not respiratory in origin. That was his DM exit exam question. So as rheumatologists today, as a lecture for rheumatologists today, I am going to show you only one slide of rheumatoid arthritis. And I'm going to show you all cases which will challenge you to think what, if you go to have you ever been to the library of KEM Mumbai? Outside the library, there is a display, a phrase by William Osler, that to examine patients without reading books is to sail an uncharted sea. And to read books without examining patients is not to go to the sea at all. So how important it is for us to refer to books, and you have living books with you in front of you who help you with morning rounds, evening rounds, who help you with, signs, symptoms, etc. Immense knowledge. So make full use of, your teachers who are here to teach you. Nuclear medicine forms a minuscule part of patient management, but it has some amazing, findings which help you in clinically challenged situations. And that's what we are going to discuss today. Let's see. Yeah. So to begin with, take a look at this patient, middle-aged woman who had recent onset eruptions, somewhat like this. So what's your differential diagnosis when you say without much of itching, no history of fever, just about 3 months, couple of rashes, one here and one somewhere down in the abdomen. So clinically, they thought that this could be either actinomycosis or, leprosy-related rash. And this is the differential diagnosis of, skin rashes. They could be host lot of conditions, contact dermatitis, infection, autoimmune disease related to sting, bite, carbuncle, melasma, etc., etc. I think this one away. And these are some examples of how, various rashes appear. Urticaria. Please. Papillary lesions, and of course, scaly lesions of psoriasis. And you have to remember one important cause in your history, that skin rashes which occur after starting a medication. So these are some of the drugs: quinine, lithium, indomethacin, antimalarials. They can all be responsible for various types of skin rashes. This patient was sent with a biopsy report, which I will subsequently share with you. And a PET CT was asked for. Now, having known that this patient already has a diagnosis, why would a physician ask a PET scan in a patient with such rashes? Can you think of various differential diagnoses where you will have skin lesions along with some systemic manifestations, which could be paraneoplastic? What else? Sorry? Yes, autoimmune rheumatic diseases. SLE, you want to check? Okay. This patient didn't have fever. There was no weight loss. There was not much of, there were no joint pains at all. There was no dryness of, various of mouth or ear, dryness of ear, of eyes. So what we found was corresponding to that lesion, there was this FDGA bit cutaneous based skin thickening, subcutaneous. Can you see that? So one somewhere in the thoraco-abdominal wall, another one in the high gluteal region. And apart from that, there was a lymph node in the neck. There was a lymph node in the right axilla. And there was nothing in the spleen. There was nothing in the bone marrow. And that was the actually diagnosis with which the patient came to us. The findings were consistent with cutaneous Rosai-Dorfman disease. And Rosai-Dorfman disease is characterized with, engulfment. Do you know what is the characteristic feature of Rosai-Dorfman? When the histiocytes, they engulf, they phagocytose inflammatory cells, so what is called as imperial process. Yeah, it's called. And this is the classification of Rosai-Dorfman. It could be non-cutaneous, it could be familial, or it could be cutaneous. It's about only 10% of cases you get cutaneous lesions. And sporadic could be either nodal, extranodal, which could involve various visceral organs. And because it could be associated with, neoplasia such as leukemia, Langerhans cell histiocytosis, etc., etc. And of course, autoimmune disorders, as you had given as a differential diagnosis. And this is a typical histologic feature of Rosai-Dorfman disease, Destombe's disease. Actually, Destombe was the first person who described this, subsequently was confirmed with Rosai and Dorfman. And emperipolesis, that's what it's called. So M is inside, and peripoliosis is going around. So, when inflammatory cells are engulfed by the histiocytes, that's how this is characteristic. And these are the differential diagnoses: tuberculosis, Kaposi sarcoma, eruptive xanthoma, acneiform eruptions, cutaneous lymphoma, and of course, Langerhans cell histiocytosis. This is an elderly patient who had lost about 11 kilograms in weight over a period of 2 months. He had difficulty in swallowing. There was nasal regurgitation. There was difficulty in getting up from sitting posture. With all these symptoms, he was asked all these investigations. Laryngoscopy because of dysphagia, but nothing, it was normal. GI-scopy was just about gastritis. Colonoscopy was normal. There was myopathic pattern of pattern on EMG, and thyroid function tests were normal. The CPK was high. So that should start, giving you some clues. And a PET scan was asked for. Now, why would you ask for PET scan in the patient who has weight loss or manifestations suggestive of polymyositis? Why would you ask for a PET scan? You have clinical diagnosis. You can do a muscle biopsy. How is PET scan going to help you? So that is paraneoplastic. That's a very good, thought, because here in this patient, you can see this was, here, that's contamination actually. Contamination. This is the injection site. So when you get hotspots at the injection site, it's because of extravasation or IV line, and that's contamination. Sometimes the blanket gets contaminated. So what you have actually is in the physiologic uptake in the large bowel, and look at the muscles. These linear uptake in the muscles is something which is seen in two conditions. If the patient is not fasting, so if you send a patient and we do an FDG, and if the patient lies that he is not had food, you do a PET scan. If you find everything is in the skeleton, it's because of postprandial state, because the glucose, insulin glucose gets activated and there is accumulation. So you have to ensure when you have such pattern that the patient has really been fasting. So if the patient is fasting and you have such pattern, it's typical of polymyositis. Corroborating this with elevated CPK is typical of, and of course, when you do a whole body PET scan, there was nothing else either in the lungs or abdomen to suggest upper primary. So polymyositis the pain could be spontaneous or on grasping of muscles. That's clinical. You have, these markers which can get elevated, various markers. EMG has typical findings. And of course, biopsy is, diagnostic of the entity. A companion case, elderly patient with loss of weight, generalized weakness and swollen extremities. Lab parameters were unremarkable, procalcitonin normal, CPK was normal. And look at that. Once again, non-fasting state. Now, that's another clinical challenge. If you go to the previous case, I just want to impress upon your mind. If you look at the brain here, brain is the powerhouse of glucose metabolism. So you should get intense uptake in the brain unless the patient is, brain dead, in which case you may not. But otherwise, you should get physiologically intense uptake. So here is another PET scan which is done in this patient. You can see here underlined blood glucose levels were deranged. So previous years when we started practice, we used to return these patients because of helplessness. There was no molecule which could be used to pick up this. Now we have a wonderful agent by the name of fibroblast activation protein inhibitor. It's called as gallium-68 FAP. So this is a molecule which goes and localizes in neoplastic cells, not cells, but fibroblasts which are associated with the neoplasia. So whenever a tumor grows, the body tries to sort of, seclude it or sort of, confine it to a particular region by activation of defense cells. These are cancer-associated fibroblasts. So they are specially modified fibroblasts, which sort of, and they comprise almost 70% of the tumor volume. So when you use FAPI in such patients in malignancy, it gives wonderful results, and it doesn't require fasting state. So you can see here in this patient, we could not be, the molecule which we used was not FDG because nothing is seen in the brain. Can you see that? But intense uptake is seen in the skeletal muscles. In addition, can you see that there are two dots here? Now, these dots could be coming from the ribs. They could be coming from the muscle. They could be coming from the pleura. So that's the limitation of a nuclear medicine technology. It has very high sensitivity, but when it comes to spatial resolution, it has its own limitations. So that's why you club it with another, anatomic imaging modality. And that's why we have a PET CT. These are two gantries fused together. So patient doesn't realize that he has undergone two sequential tests in one go, in 20 minutes time or 5 minutes, 7 minutes, depending on what system you have. So sequentially these two. So now when we do a cross-sectional imaging, you see that's the breast soft tissue lesion here in the breast, which is hot on FAPI scan. And there's something in the lymph node, which was also hot. So this was occult primary in the breast, which was accounting for all manifestations as, paraneoplastic manifestations, polyneuropathy. So what is the relationship? You already know that, there is higher incidence of malignancy in polymyositis. And if the risk mounts up further if the patient is also a diabetic. So actually there was a paper related to this and I don't know, it's not here anyway. So here's a patient who had fever, intermittent joint pains, known systemic lupus erythematosus, and the patient was treated in the past for SLE and recently was on anti-inflammatory for fever. And then because of fever, the patient was referred to us for localizing occult infection. So what do you see on this scan? You can see that there is intense uptake in the brain. So this is an FDG PET scan. What else can you see? That's uptake in the myocardial. Myocardial uptake on FDG could be physical. It's extremely variable. It can be physiologic. Absence of uptake also is physiologic. And I'll not talk in details about that. But there are some hotspots you can see here. That's on the kidney, but you can see here in the retroperitoneal station, there are hotspots, multiple hotspots in the mediastinum. Can you see those? All right. So let's do this cross-sectional and look at that. That's the left para-aortic node. You can see that's hot. There's a thoracic inlet node, which is hot. There are nodes here in the mediastinum, paratracheal, AP window, retrosternal. All these nodes are showing intense FDG uptake. And what else? Look at the lung window. There is a pleural-based granulomatous sort of shadow, and there are multiple smaller lung nodules. Can you appreciate those? Multiple smaller lung nodules. So with that picture, with history of fever, with past history of treatment with immunomodulators, what could this be? Yes, tuberculosis, because fever. And so this was patient was biopsied. It was granulomatous and put on anti-tubercular treatment. He recovered completely. 1 year down the line, this patient developed dysphagia. So he was in AKT and he developed dysphagia, and that's when he was referred to us for an FDG PET. Now, what do you see? What is the difference between these two scans? Sorry, go back. So that's the one which was done earlier on. And this is after 1 year after completion of anti-tubercular treatment. What do you see? Are these nodes in the abdomen still there? They're resolved, haven't they? There were nodes in the mediastinum paratracheal station, probably resolved. There's a new hotspot here. And there's a new area of tracer uptake which appears to be more intense somewhere in the midline of thorax. So look at that. That's the previous scan. The retroperitoneal nodes have resolved. Can you see this? This is the current scan, and that's the old scan. This is the current scan. There is a hotspot which is localized to the upper thoracic vertebra. And this was not there previously. Can you see that? And there is something in the middle mediastinum or posterior mediastinum. That's this was not there previously. At the level of carina, there's a new uptake, which is esophageal thickening. You can see that. That's the vertebral uptake. And this is the left side is the old, and that's the new one. You can see that has reappeared. This one has shrunken, almost a fibrotic shadow, and the smaller lung nodules had regressed. So what is this? This patient has dysphagia now, and what is this likely to be? Malignancy, esophageal malignancy. What could be the relationship between the two? Can you think about it? Any PG who can think about this? What could be the relationship of SLE in the past, tuberculosis in the past, which was effectively treated, and now the patient has developed dysphagia? Any exam going student? Sorry? Well, this is a pretty thick, area of uptake. Yes, it's one differential diagnosis, but it's a mass-like lesion. It's not like mucosal superficial lesion. It's more. So this patient was given cyclophosphamide for SLE in the past. You saw my first slide. Patient was treated with endoxone. And you all know, now you know that, you have to pay how much importance you have to pay to the history. The risk of cancer after cyclophosphamide treatment in various conditions. You can see here, there is threefold increase in malignancy. So you have to use this drug with caution, and these are the various type of cancers, CA bladder, CA prostate, RCC, larynx, lung, AML, NHL, whatnot. All this, this drug predisposes a patient to all these. Here is another patient who had fever, weakness, about 6 kilograms of loss of weight. And patients, because of female patient, they did a CA125, which was normal. They also did serum electrophoresis. There was no M band. However, there was some monoclonal gammopathy in the form of IgG being high. You can see 2000 as against the normal value. But the patient was referred for occult infection, stroke, malignancy, or myeloma for that matter. And that's the whole body PET scan. You can see here. No, the memory is insufficient. That's why it's not playing. Yeah, that's right. Anyway, so what you're seeing in the colon, which is physiologic, in the kidneys, which is again physiologic, and nothing much here. If you, on a closer look of the abdomen, we saw that there was something at the bifurcation of aorta. Can you see that? There's a ill-defined soft tissue in at the bifurcation of aorta, which is sort of engulfing and the vessels here, and with heterogeneous metabolic activity. So this was the only abnormality which was seen on cross-sectional imaging on the PET CT scan. And sorry about this. Once again, I'll impress upon you from this place. Anyway, IT people, yeah, look at that. So these are the kidneys, and that's the ill-defined soft tissue, which is sort of engulfing the bifurcation of aorta. So based on there was nothing in the skeleton. What else would you look for? You would look for osteolytic lesions in the skeleton. There was none. There was nothing in the spleen, this was the only finding. Based on the background which we received, the raised IgG levels, we said that there's a possibility of this being either granulomatous, of course, or IgG4 related disease. And so increased uptake in the kidneys also. And so this patient had, eventually when we followed up, the IgG continued to be high, as here almost 2 times, and was diagnosed as IgG related disease and treated with steroids. So what are the diagnostic criteria? There are 3 important parameters which are with you. One is clinical radiologic, second is serologic, and third is pathological. And of course, to have a definitive diagnosis, these 3 have to be positive. And for probable diagnosis, should have 1 and 3, and for possible, these 2. So important is more than 50, what is that? Milligram per deciliter? Is that what? Yeah. Of IgG, no, more than 50 IgG positive plasma cells in serum, or more than 10 IgG positive plasma cells in biopsy. So that's the pathological criteria. That's a paper atlas article of FDG in PO. Coming to our next case, patient with 4 kilograms of weight loss, recent origin, 2 weeks. There were no seizures, and there must be some reason why I'm showing you this case after an IgG related disease. Okay, so loss of weight, there was headache. She said that there is some loss of taste sensation. You can see here, taste is reduced. Tears are intact. What does that mean? So when I began this talk, I said, we are going to have only 1 slide of rheumatoid arthritis, because we do not want to, rheumatology, you can teach me rheumatology. I want you to open up your mind and practice medicine as much as you practice rheumatology. So what happens if a patient has loss of taste? Which nerves? Cranial nerve. Come on. Cranial nerve? 7. Any other cranial nerve? Yes. So you know your subject. Absence of dryness of eyes. Absence of dryness of that rules out. Dryness of eyes. See, there's a mnemonic for facial nerve palsy. What is that? Close your eyes, taste the pie, and cry. So when you close your eyes, facial muscles get activated. So that's the motor component. When you taste the pie, and if you do not like it, you cry. So that's tears. So the the parasympathetic component is through the facial nerve. So here you go. So this patient was sent to us for a PET scan. And once again, as usual, we didn't have FDG. So we said we'll offer you which scan? FAPI. So gallium-68. So F18 fluorodeoxyglucose is F18 is the radioactive compound, and you need to have a molecule which will drive the radioactive isotope to a particular organ. So that is glucose, deoxyglucose. Similarly, when you do a FAPI scan, it's not fluorine labeled, it's gallium-68 labeled. So why I'm explaining this to you, so when you enter into practice, you can always command to your nuclear medicine. You don't have FDG, why don't you use FAPI? Gallium-68 comes in the form of a generator, and you can extract it any time of the day. So if the patient is fast or having high blood sugar, is non-fasting state, you can still do it. So here, this patient underwent a FAPI scan. Now, what is this I'm trying to elicit? The patient looks to the right and there's no problem. But when she's looking towards the left, this is deviating here. What happens to the left eye? So which muscle is, which nerve is that? 6, yes, so abducens. Now, which foramen is likely to be affected if there is abducens nerve involved? Does it pass through the foramen rotundum? Does it pass through the foramen ovale? No. Does it pass through the spinosum? No. So it goes via, stretch your memory. Yes, you're right. You know your subject. I'm glad. So what is this I'm trying to elicit here? If there is one cranial nerve involvement, more than you would like to try to elicit abnormality in others, isn't it? So what am I trying to elicit here? No. Yes. So if there was left hypoglossal palsy, where would the tongue deviate? Good. So you know your subject. I'm glad. What is this I'm trying to demonstrate here? Accessory. Yeah, right. Yes. 11. So this patient underwent an MRI. Excellent students, excellent teaching, I must say. Dr. Varsha, Kavita ma'am. So this patient had a mass in the orbitofrontal cortex here. So obviously, of course, they were suspecting malignancy, and that's why the patient was referred for a PET scan. And you can see here there was a mass. There's a mass here in the right upper lobe. There are deposits here. There's a deposit here in the bone, iliac bone. Now, coming to the science and correlating the science with our skull base, lovely skull base. So what's that? Pituitary fossa, the cell actor sacra. And we are talking about the involvement of which nerve? Abducens. So what is probably responsible for that abducens nerve palsy? This deposit in the cavernous sinus, which is probably responsible for, you will not be able to finally demonstrate it. It's not possible to, but you can, sort of correlate, and you can ensure that we are dealing with this. Okay. And of course, there was something in the foramen lacerum, which is the path for tears. Greater petrosal nerve. No, greater petrosal nerve, it goes via the foramen lacerum, foramen rotundum, then joins a branch of trigeminal nerve, nasolacrimal, and then gives to the ciliary lacrimal gland. That's where. So that's why at the beginning when I said that there is no dryness of eyes, this is the reason. And the patient had loss of taste sensation. So nothing in the external auditory canal, nothing in the passage of facial nerve. What could be responsible? So where will you expect the abnormality if that's the case? Which foramen? Sorry, you said it right. Somebody said that. Yes. Jugular foramen. That's where. So what are the two parts of jugular foramen? Pars vascularis and pars nervosa. It's sort of, conflicting, because pars vascularis actually carries two large nerves, and pars nervosa carries only one large nerve. So now it's simple, 9, 10th, 11. Pars nervosa carries 9th, and 10th and 11th are carried in the pars vascularis. So which one is lateral and which one is medial? The lateral is the pars vascularis, and the medial is pars nervosa. So you can see here, this is the medial of the two. Pars nervosa is showing a hotspot. So I told you what are the manifestations of facial nerve involvement. Now, what are the manifestations of involvement of glossopharyngeal? You know, I am very selfish. I am doing it because I just want to revise this. So this is about the, now you can see the patient had lateral rectus palsy. Look at the diagram of cavernous sinus. The sixth cranial nerve is embedded within the cavernous sinus, and other nerves, the oculomotor, the trochlear, the P1 and B2, they are all in the lateral wall. So this is at most risk when the cavernous sinus is involved. That's now coming to the manifestations of glossopharyngeal nerve. Now I have a, yeah. So would you like to know about this? Yes. How would you like to memorize this? This is a very simple way to memorize. You know, if in a childhood, if you were ever slapped by your parents, boys, if you ever slapped by your parents. So the first manifestation is pain. You have been slapped, even a tight slap, pain coming from the Marathi म्हण Kana khali bazuka. Marathi has a very, insinuating, insulting jokes, humor sort of. So pain in the middle ear, pain coming from the mastoid, pain coming from the eustachian tube, pain coming from the palatine tonsil. So the first manifestation. The second reaction as a child you have is anger and bitterness. So bitterness is a taste which comes from the anterior third is already taken care of by facial. So the posterior third, the palatine tonsil region. That's so special sensory afferent is taken care of by the glossopharyngeal nerve. And you said you're angry. So when you are angry, you want to your blood pressure rises. So when the blood pressure rises, what happens? Which particular area comes into activation? It's sensed by carotid. So carotid, baroreceptors and carotids come in. So the general visual afferent is taken care of by the glossopharyngeal nerve. Now what remains is, because you're angry, but would you shout back, answer back to your parents? You will not. You want to swallow your anger. So the swallowing requires lubrication. This lubrication is provided by a salivary gland, parasympathetic, carried out by parotid gland, because you have been slapped on the lateral side. So parotid gland. And finally, because you swallow, and this anger you've swallowed, you share it with the third person. You will share it with your friend, your brother. You will not share it directly with your parents. So this muscle supplied by the third pharyngeal arch, the glossopharyngeal nerve, and the superior constrictor are supplied by the. Isn't it interesting? Yeah. This patient had fever on and off. This was recent. And she had some rashes, which was also of recent origin. She had long-standing joint pains, which aggravated lately, and lost about some weight last 3 months. With these symptoms and signs, she came to us for a PET. With this, that's the hemogram, where it's quite unremarkable, except that the WBC counts are borderline high, almost reaching 10,000. And she underwent an MRI, which did not show much except some degenerative changes. And that's the PET scan which was done. Now, what do you see on this FDG PET scan? I'm sorry. Can you see that there's something in the region of shoulder joint? There's something there in the region of hip joint. Now, let me show you that better. That's in the symphysis pubis region, osteitis pubis. There's something in the region of greater trochanter. So that is trochanteric bursitis. And you have splenomegaly, splenic span is high. There's a tiny nodule in the lung. So with these findings, and of course, that's facetal arthropathy over here, and dilating lung nodule again. And of course, shoulder joint, I told you. So multiple joints inflammation, and you have organomegaly, fever, weight loss, no other findings. What could this be? As a differential diagnosis, we talked in the earlier case. Fever, weight loss, rashes, leukocytosis, hepatomegaly. What is a what is an important differential diagnosis? So adult onset Still's disease versus, so in children, it's called a juvenile idiopathic arthritis. And these are all the manifestations. Patient has leukocytosis. And of course, these are the markers, important serological markers, which help you come to the diagnosis. We've asked for ferritin in this patient. We not yet received the report. And these are the various sort of chart for explaining adult onset. So there's a phase of pathogen-associated molecular pattern, damage-associated molecular pattern, and resolution-associated molecular pattern. And differential diagnosis, of course, is rheumatoid arthritis, SLE, reactive arthritis, polyarthritis nodosa, lymphoma, and Ponson's disease. Have you ever seen a patient of Ponson's disease? Yeah, very good. This patient had backache lasting 6 months. She had history of trauma. MRI was unremarkable, films were not available. Bone scan was done because they thought this could be inflammatory arthritis. Okay. So have you ever ordered for a bone scan, technician bone scan? Have you ever seen how it looks? Because people nowadays, have you ever seen? How is it performed? Unlike PET scan, it's performed on equipment which is called as a gamma camera. So PET scan is a different device. Gamma camera is a different arm of nuclear medicine. And the isotopes which are used are also different. They are lesser in strength and labeled with various different compounds. So here, methylene diphosphonate is the component which is administered, labeled with technetium, and it goes and localizes over a period of 3 hours. So you administer, acquire one initial image to look for synovitis, and then wait for 3 hours and acquire the actual uptake phase. So you know the difference between structural imaging, such as X-ray and technetium bone scan. You know what is the fundamental difference? One looks at the structural abnormality, which means that for an X-ray, unless it's an acute traumatic fracture, for a pathology to show abnormality on X-ray, there has to be a demineralization to the tune of 35% to 40% before it becomes visible on the plain X-ray. Whereas for a nuclear medicine scan, it shows after the onset of insult, there is increased osteoblastic activity in the given region. So it shows manifest abnormality within 24 hours after the onset of insult. So if you get a trauma, whether that trauma may or may not cause fracture, it may have caused just a bruise, it may have just caused a periosteititis or minor degree of inflammation, whatever, or or infection for that matter. Any insult in any form, whether it's malignancy, tumor, inflammation, will show up on a bone scan within 24 hours. So that is the fundamental osteoblastic activity. It's a functional abnormality. So here you can see the patient's inflammatory markers were normal. The PTH value was also normal. You see, and with that, the patient came for a bone scan. That's the second phase where, some degree of increased uptake is seen in the SI joints. And you can see here, multiple hotspots on a bone scan in the ribs, SI joint. Here you can see here is something which is looking like loser zone. Now, why are loser zone formed in patients of osteomalacia? Where losers, how do they appear? They appear as linear osteolytic areas. So they are essentially, bone osteoid material which is not mineralized. But why linear? Because they tend to form along the nutrient vessels. That's why you have osteoid, which is unmineralized, and that's why you get osteolytic. So there was something like loser zone here. And because this is a typical pattern you also get in metabolic bone disease, such as hyperparathyroidism. But the patient's parathyroid hormone was normal. So what else can be the differential diagnosis? I would have loved to meet Dr. Omkar Wagh. He's not here today because he thought, no, not in this patient, we'll come to the next page. So we thought that this patient is tumor-induced osteomalacia because of typical metabolic bone disease pattern, but the patient was lost to follow. There was yet similar case, a companion case here, where the patients had bilateral neck femur fracture, calcium was almost normal range, PTH was on the higher side. You will think that this is sort of osteomalacia. Vitamin D was normal. Alkaline phosphate is high, I think here. And the patient was suspected to be primary hyperparathyroidism for whatever reasons, and the scan was negative. You can see here, that's the technetium scan. This is sesame scan. You subtract the two, you should, whatever you get should be in the parathyroid gland. This was negative. So Dr. Ungar Wang saw this patient and he said that the patient's phosphate level is low. Serum phosphate level, that's a very important marker, which is low. And then he did fibroblast growth factor 23, which was high. And then he suspected that this could be tumor-induced osteomalacia. And when you have tumor-induced osteomalacia, you don't ask for an FDG PET scan. The isotope of choice is called as gallium somatostatin receptor PET scan. So that's another important, message for you all, that not all PET scans are equal. You have heard of FDG, you've heard of FAPI. Now I'm talking about a somatostatin receptor PET scan, which is used in tumor-induced osteomalacia. So this patient underwent, and that's the suspected area in the vestibule, oral vestibule in the gingivobuccal sulcus, and we suspected occult primary. These are usually fibroblast tumors, which are connective tissue tumors, which are responsible. They could be malignant also, but it's a curative method actually to treat these patients if you excise them. And that's the you can see here in somatostatin receptor or the dotatate PET scan, nothing in the brain. Intense uptake in the spleen, which is physiologic, uptake in the bladder, and here, this was the abnormality in the jaw. All the neuroendocrine tumors. Neuroendocrine tumors is another important entity where you look, because neuroendocrine tumors are all slow proliferating tumors. You have to remember, all slow proliferating tumors will be falsely negative on FDG PET scan. So the same is applicable to carcinoma of prostate. Patients who have signet-ring cell carcinomas, patients with neuroendocrine tumors, including paragangliomas, will be falsely negative on. There will be occasional situations where the tumor has dedifferentiated, in which case you may get you may get FDG positivity. But largely they'll be negative on FDG. That's why you go for a DOTA scan. So here's a young patient. Now, we talked about IgG-related disease. What was the older terminology for IgG-related disease involving the pancreas? Autoimmune pancreatitis. Autoimmune pancreatitis was. So here's a patient who was admitted for pancreatitis in the past. The patient's calcium value is high. Patient's PTH is also high. You can see that. With that, you will definitely suspect primary hyperpara. So patient's X-ray did show osteopenia, and that's technetium, which goes to thyroid, sestamine, which goes to thyroid and parathyroid both. Without moving the patient, you administer these two isotopes, and then computer does the subtraction. So you program it, and then you can see here, that's the parathyroid adenoma, which is picked up on the SSMEP scan. This is a very interesting clinical presentation of a patient who had dryness of mouth, fever, the ACE levels were high, and the patient had backache. So she was sent to us for a bone scan, and we said that there is uptake in the lumbar region, there was uptake in the mid-thoracic region, there's something in the ribs. And we said this was pretty long time back, actually, 2009. So we said this is probably multifocal skeletal tuberculosis. Because that's one important reason. This thing, because so the patient was put on AKT and the patient did not respond at all. So the physician called back that this patient has parotitis and I am suspecting SLE, or I am suspecting inflammatory disorder like maybe sarcoidosis. So whether you can do anything which will help me, because taking a biopsy from the bone is difficult, and the yield also is limited, including in malignancies, yield is limited. So I said, we'll do an FDG PET scan to look for any visceral organ involved. And fair enough, you can see here, when we did a PET scan, look at the liver. There's increased inhomogeneous distribution in the liver parenchyma, and there are multiple hotspots in the vertebrae. And look at that. This pattern of diffuse inhomogeneous increased uptake, patchy uptake in the liver is some infiltrative disorder. And we said this is likely to be sarcoidosis, granulomatous involvement, or of course, it could be tuberculosis for that matter. But the patient had failed to respond to antitubercular, so it was unlikely to. So she underwent biopsy and it was non-caseating granuloma, typical of sarcoidosis. Companion case, hefty fellow, lost weight recently, had recurrent cough. And as I said previously, that uptake in the myocardium can be variable. So here when we did the cross-sectional imaging, is the uptake of in the thorax corresponding to the myocardium? It is not. It is corresponding to the pericardium. Can you see that? It's corresponding to the pericardium here, inferior pericardium, the anterior pericardium. And when we did the corresponding MRI, you can see the pericardium is thickened, edematous, and homogeneous increased uptake. So what could this be? Pericardial affection in a well-built patient who has lost weight, was recurrent cough. What could this be? But because of what? There has to be some, it could be tuberculosis. I thought it is tuberculosis. And the patient had pericardial biopsy. Is it because the Zoom says that time is over, or what is the reason it's not moving? Okay, that's it. All right, so you can see here, the patient had pericardial biopsy, and once again, this was granulomatous, non-caseating involvement of the pericardium, typical of sarcoidosis. Published this case later on in one of those journals. And sarcoidosis, of course, can have varied manifestations. It could be incidental lymphadenopathy, it could be fever, arthralgia, skin rash, eye involvement in the form of uveitis, conjunctivitis. In the myocardium, it can cause bundle branch block, ventricular tachycardia, congestive failure. In the nervous system, it can cause cranioplasty, etc., etc. And 10% of patients may have elevated calcium because these macrophages, they produce 1,25-hydroxy calcitriol, and ACE level is elevated in about 40 to 90% of patients, once again, because the epithelioid cells, they produce ACE. This is our publication. The same case was published in one of the journals. Coming to, as I said, rheumatoid arthritis, the reason for today's talk. So you all know about this. So I'm not going to waste my time. These are the various cardinal manifestations, diagnosis, all this. So you need to do basic clinical tests, disease-specific tests, systemic involvement, disease activities. And these are the various reasons where you may get false positivity of RA factor, cirrhosis, Sjogren's syndrome, polymyositis, sarcoidosis, all this. So RA positivity does not necessarily specify towards rheumatoid arthritis. And that's relatively highly specific, you know that. So here was a patient, elderly man, who had lost 10 kilograms of weight and had been having joint pains for 4 years duration. Sorry for that. This was a real life. You can see a 10 kilograms of weight loss and multiple joint pains. All these investigations were done. And then, of course, MRI, which was just about, degenerative changes. And then he had HLA-B 27 positive, and he was referred for a bone scan. Look at the bone scan. There was facetal arthropathy in the mid-thoracic region. There was something here. There was uptake in the small joints of the hands. You can see here, small joints of the feet. So with that, history of so much of weight loss, and this is not typical of monoarticular, involvement of tuberculosis. Tubercular involvement is relatively intense in particular region, maybe in the vertebrae or ribs, or, this is not typical of tuberculosis. We said, what else can this be? Patient who has arthritis for a long time, he has recently lost weight. And this Ponson's disease, we talked about it. You said that. So this patient we said possibility of Ponson's disease because polyarticular involvement, inflammatory, and recent weight loss. Those days we didn't have PET, I think. That's why, based on the, these findings, the patient was put on AKT and recovered, remarkably. This is the difference between tubercular arthritis and Ponson's disease. These are sterile inflammatory joints, multiple areas, no organisms will be, obtained here, and they resolve it. The inflammation resolves with anti-tubercular treatment. This patient had done very well. This patient was suspected to be having metastasis because she was operated for carcinoma of breast, treated for carcinoma of breast, and was sent with the suspicion of metastasis. And this is the only slide of rheumatoid arthritis which I have in this presentation. You can see intense uptake in the synovial joints, at multiple sites, wrist joints, small joints, elbow joints, shoulder joint. You name a joint and it's involved. So this is a typical rheumatoid arthritis. The patient had not informed about this to the doctor and RA factor was positive. Another important challenging situation before a physician, especially if you are a rheumatologist, if you are a internist, young patients, especially working in the IT industry, confined to a conditioned atmosphere. This was suspected to be seronegative spondyloarthritis, vague joint pains, backache, etc., was referred to demonstrate evidence of synovitis, arthritis, because they thought this is seronegative. And there was nothing whatsoever. It was a plumb normal FDG PET scan. So whenever you have such an abnormality with genuine symptoms, these people are working, they are earning members of the family, you have to think of one. I give you a clue. Air-conditioned atmosphere, confined to household, with not exposed to the sun, vitamin D deficiency related osteomalacia. Young patients, we have seen patients, respond dramatically to a shot of vitamin D and calcium. This patient had some, osteomalacia. Normal, ma'am, plumb normal. You may get some areas of osteopenia here and there, but otherwise it's going to be plumb normal. You don't expect any abnormality. So a normal, that is in the bone scan, ma'am, because bone scan, that's what happens in bone scan, because the osteoblastic activity of the skeleton reactivates, as I said, in response to any derangement, whether it is inflammatory related, neoplastic related. Here it is metabolism related derangement, which causes the bones to react and cause increased hotspots, multiple. And the kidneys, which are normally seen on a bone scan, will show very diminished uptake. So that's another important clue to metabolic bone disease. But that's not valid for FDG PET. FDG PET, you will see the kidneys in either area. So here is a patient who had middle-aged patient who had rib pains, inguinal pain, vague pain, aches and pains. With all these, the PTH was normal. Electrophoresis was not typical of myeloma, and MRI was done. MRI was just there's nothing except for some disc bulges. There was nothing, and a bone scan was ordered. On the bone scan, you can see there are no hotspots confined to any discrete hotspot. But what you have is diffuse uptake in the region of skull vault. If you look at the ribs carefully, there's linear increased uptake here. Look at that. Sorry. So linear uptake in some of these ribs. Can you see that? This rib here, this rib here, this rib, and some inhomogeneous increased uptake in the vertebrae. Based on these findings and based on the fact that the patients, I don't have the hemogram here, unfortunately. This is from our records. So we said this is not falling in metabolic bone disease pattern. This is not falling in the pattern of inflammatory arthritis. And the patient has symptoms which are genuine. Patient has recent onset symptoms. And we said that this could be some hematologic disorder. So we asked for an FDG PET scan. Luckily, the consultant agreed. And look at that. This patient has intense metabolic abnormality in bone marrow involving the axial as well as appendicular skeleton. The bone marrow of the humerus, femur, pelvic bones, all the vertebrae, sternum, everywhere there is increased uptake. So we said this is likely to be hematolymphoid malignancy, and it was actually a case of leukemia. And there are some notes here and there. And this is a Atlas article on skeletal manifestations of hematologic disorder. So FDG PET is a sensitive tool. Bone scan is a preliminary investigation in rheumatoid arthritis, can effectively pick up inflammatory synovitis. If there is resurgence of symptoms on treatment, then FDG is a good test to identify the extent of disease activity. It's very objective. It's not, you don't have to depend on the words version of the interpreter, like an ultrasound, you have to depend upon the interpreter. Here you can ask, where is the synovitis? You want to see it yourself. And it helps in identification of visible organs, as we just demonstrated in some cases. And you have to remember there are great mimickers of arthritis in the form of various disease entities. So to end, this is a saying, George Bernard Shaw. There are two types of individuals. One are in the world. There's one are reasonable, the other are unreasonable. The reasonable ones, they adapt to the world. And the unreasonable ones want others to adapt to them. You might feel that your professors are sometimes being unreasonable, but remember, all your progress in your career is going to be made by the unreasonable person. Thank you very much for your time, attention, and
But getting vasculitis, that's like.
oh yes. Actually, I should have made a phone call to ask you what. Yes, it's a extremely sensitive tool in aortoarthritis. In patients who are suspecting Takayasu aortoarthritis, in patients where you are suspecting graft infection for that matter. It's an extremely objective way of demonstrating vasculitis. Yes, I'm sorry I did not bring aside one case. I was too preoccupied, preparing all this. I should have called you. Yeah, vasculitis is a very important. Oh yes, as I said, yes. Whether it is tuberculosis, whether it is sarcoidosis, and tuberculosis especially, you want to know whether it's good time to terminate the treatment. This is an extremely good tool. If you have activity demonstrable on FDG PET scan, you must continue AKT. And the same is valid for inflammatory synovitis, arthritis. You want to step down the medication, you can take the help of FDG PET scan. You want to know whether symptoms are genuinely related to synovitis or something else which is going on. This is a very effective way to demonstrate there is abnormality in the joints or not.
Guidelines are not very clear. We should be taking an FDG PET.
As far as diagnosis is concerned, ma'am, it's very effective.
But follow-up and all.
For follow-up, even I'll have to read about it. Whether I'm sure. What are your concerns when managing patients of vasculitis?
The disease activity would be not indicated as such for the remission of the disease apart from clinical indices. But when to continue the therapy.
So how do the serological markers help you? So are there situations where you have serological markers which are normal and you that's when we will FDG PET is, as I said, extremely sensitive. Whether disease activity is still there or not, we'll definitely be able to tell you.
What is the quantity or quantum of uptake on the?
Well, the intensity of uptake can be mild, moderate, intense, depending upon, it's all qualitative. Quantification, it's called as standardized uptake value of FDG. On, you do a standardized uptake, you measure it, but it has no diagnostic value. It has a prognostic significance. So if you have a patient, you want to know in a lymph node, for instance, an FDG of 25, whether it will help me differentiate between malignancy and tuberculosis. No, the answer is not. But at onset, it was 20, and on follow-up, it has become 5. That's a measure of response to treatment. That's
most of the times in myositis, let's say, for example, our patient is on steroids for the disease activity per se, and we want to get a PET CT to look for occult malignancy. But a lot of times we cannot taper the steroid because the disease activity will flare at that point of time. So how does steroid hamper the PET CT?
As I said, in a patient with suspected occult primary, FAPI PET scan will overcome this because it is not going to be interfering with this. FDG PET, if there are occult lesions in the breast, they will be picked up. If there are occult lesions in the GI tract, we have limitations because, as I said, signature cell carcinomas, serous cystadenocarcinomas of ovaries, they can be falsely negative. And to overcome that, we have new molecule in FAPI, we can use that. But largely speaking, if we have not had encounters where because a patient was on steroids, we have landed up with false negative. We have picked up.
Then CT can still be done if the patient.
Oh yeah, sure.
One of our cases, we had a query like that. We had to taper the steroid.
So if you want to look for disease activity,
No, not for, it was only for malignancy.
No.
Lymphomas or malignancies.
if you are thinking of lymphoma, it's true that steroids will interfere with uptake of lymph nodes. Definitely it's going to, but occult primary, other than, lymphomas are very sensitive to steroids. They melt with, administration of steroids. So that's one situation. Yes, of course, it's a good option. And it's a, yes. Yeah, it's an extremely sensitive and same, ma'am. 15,000 rupees is what we charge for FAPI. And for Bharati, of course, we have a special rate. You all know that. And, we do FAPI for the same rate for what we do for Bharati.
CT part, PET CT, radiation.
That's one reason, madam, that in young patients with young females especially, I avoid doing a contrast CT. I've seen people doing plain CT and then contrast CT, and there's so much of. So my protocol in a young female with suspected CA breast, I do a non-contrast PET CT and do a liver MRI just to ensure that we are not missing anything in the liver, because a non-contrast CT may sometimes miss liver lesions. So we do a complementary MR of the liver, because non-contrast MRI is far superior than a contrast CT for picking up small liver lesion. So that's our protocol for all cases with young. So barring GI tract malignancies in abdomen, it's a bit difficult to use non-contrast. So I had majority of the cases with GI malignancy. In patients with liver abnormal malignancy, you're suspecting, I use contrast. All abdominal cases I use it. GI rectum, CA colon, I use contrast. But other than that, head and neck, I don't do contrast. For lung, you don't need contrast. For breast, you don't need. For bone malignancies, you don't need it. Yes, the difference. There's a distinct difference between the two. The uptake in the normal is pretty homogeneous, and it's patchy in inhomogeneous increased uptake in patients of any inflammatory disorder. It will be patchy. Sarcoidosis especially. And qualitatively also, the intensity of uptake is much higher in sarcoidosis as against general normal patient. If CRPS scan, how do we differentiate between the arthritis versus CRPS? CRPS? Oh, regional pain syndrome. So, reflex sympathetic dystrophy, that's what you used to call it. So, they have a typical vasomotor abnormality. We do not, in arthritis, you have abnormality confined to one joint. In the first, second phases of bone scan, where you administer and acquire the vascular phase, in chronic regional pain syndrome, you have intense flow of isotope, diffuse increase uptake because of vasomotor abnormality. Whereas in arthritis is confined to that particular joint. It's focal. And when it comes to the delayed phase, once again, in arthritis, you will have uptake which is confined to those joints which are involved. Whereas in complex regional pain syndrome, you will have diffuse uptake in multiple phalanges, in the small metacarpals, in the carpal. It's diffuse increase uptake. It's a typical pattern which will help to differentiate between the two.
These topics, sending it for
5 days. Depends upon if it's a short acting 5 days.
Or send for
or you can send for. Yeah, sure.
It's the same.
For Bharati, it's the same. We charge outside, it's 15,000 rupees for FAPI, but Bharati, it's the same.
Vasculitis also, anytime we give patients steroids. It's like most patients have open scan.
If you are wanting to know if vasculitis is ongoing or not, the patients can be sent on steroids. There is no problem at all.
Then you can decide whether to do FG or
We usually, if the we usually do FDG, but if you, I mean, FAPI will be as effective.
You've done any
We have done a few cases, but our confidence level is higher with FDG in vasculitis. Well, there are some tumors which may be falsely negative, just as they are negative on FDG. So paraganglioma is one of them. Multiple myeloma may be falsely negative, means you may get CT abnormality of osteolysis. Then I think you have renal cell and paraganglioma, renal cell carcinoma. These are few, 3 or 4 areas but we have picked up one renal cell carcinoma on FAPI also. But in books they say that. But I think it's going to come of age, and FAPI will in future. It has a potential of replacing FDG because of no stringent, regulations, requirements of fasting state any time of the day, and off the shelf. That's a big advantage.
The reagent is different or the machinery also?
No. It's scanning is the same. Scanning is the same. The PET CT is the same. It's the isotope which is different. Just as somatostatin and dotatate is a different molecule. It's a different molecule. Yes. Yes. Yes.
Has been said possibly meningitis.
FAPI. You're suspecting anything in the brain, you have to think of FAPI. FAPI is absolutely amazing. It gives you very good results.
Superior to an MRI with contrast.
Ma'am, MRI is, as far as spatial resolution is concerned, is far superior. So spatial resolution. Whereas sensitivity of an abnormality is concerned, FAPI will localize only to abnormal areas. If it's chronic area which is indolent pathology, it will not localize. So it's only in active inflammatory pathology, neoplastic pathology, it will localize.
Very logistical question. Sometimes it's how much time the actual procedure takes for bone scan, PET scan. So, and what instructions do you need to give patients before scanning?
One important, we've devised a 3-tier billing system in our clinic. My regular cost of PET scan is 21,000 rupees. To pay 21,000 rupees, I will release the report in 2.5 hours. I will ensure everyone is on his toes. You come, I'll, personally, my technologists will personally attend, inject. Within 1 hour, we start the scan. Within 1.5 hours, we finish the scan. Within next 1 hour, I will generate the report. I will have it reviewed with my colleague, and I will release the report. 21,000. Everyone else is in the economic category. 16,000 rupees, 14,000 rupees, and for Bharati is 9,000 rupees or 8,000 rupees. I don't know. All other patients have it is first come, first serve. And what suits us? Honestly, it is difficult to manage. Unlike ultrasound, MRI, CT scan, nuclear medicine is extremely, time competitive. We are racing against time. FDG decays every minute. By the time it comes to Lonavala from Mumbai, it has decayed 1.5 life. By the time it reaches, it's decayed another 25%. I have to inject 8 patients or 7 patients at a time, wait for the first 5 patients to be over, to be able to inject next 7 patients. And, it's extremely, you cannot have slots defined, MRI 25 minutes for this patient, next 25 minutes for this patient. You cannot do that in nuclear medicine. It's no matter what, nowhere in the world, people in United States, they do only 4 scans, 5 scans, Europe on a system. If you give me only 4 scans in a system, I will give you 4 time slots, and I will ensure that every patient is released within 2 hours. Some patients of prostate cancer require a delayed image at 3 hours. That's a different story, because it's an inherent requirement of the kinetics of the isotope. But I will release every single patient in 2 hours time if every patient is willing to pay 21,000 rupees. I buy equipments in US dollars and I recover in Indian rupees, which is 65. It used to be 65 times higher. Now it is 83 times higher. So I have to work as that much harder. It is sheer passion. nuclear medicine is not money spinning business. People have invested, people have realized that, and with stringent regulations, it's stringent regulations of manpower requirement and, radiation safety requirement, all this, it's too burdensome. So you have to tell other than Jaiga. 5 hours, 6 hours, you have to be willing to spend 5 to 6 hours before I can release. They have been, and that's the reason why we have 2 PET scanners. We do not, it's a highly service oriented clinic. We are not businessmen. We want that our patients be attended promptly. But, sometimes a child who is sleeping has to take precedence over somebody who is a normal, otherwise. For an elderly patient who is gasping for breath, who is come in an ambulance, who is with cardiac failure, you need to give him preference over others. So all these factors, you cannot divide, time slots for patients. You have to, that's one reason why I said we have this segregated, and I also tell my patients that if you want economic category, please bring only 1 attendant at a time. Everyone comes with 4 attendants, with the result that with 10 patients, we have 40 attendants waiting at my reception at any given point in time, making people think, "Arey, kiti gardi hai, gardi nahi baba, tumi lokan se." It is all, related to, and you cannot, our social structure is such that if I resist Kiran and all everyone, is against me. You have no business of interfering. That is good in the interest of the patient. We cannot say you can't be socially aggressive. You can't, although I have defined that, only 1 attendant with the patient if you want economic category. Do you think they listen? They would.
GS Shikant was there.
Yeah.
Yeah, so
And
he was doing for lower GI bleeds and all.
yes, we still do it. RBC tax. Oh, yes, ma'am. RBC tax study is a wonderful, because patients who have had blood loss, GI blood loss, whose upper GI scope is normal and lower GI scope is normal. If whose angiography is likely to be normal, because when for an angiogram to be positive, the rate of loss of blood has to be of the order of 0.5 ml per minute. Whereas for a radionuclide study to be positive, the rate of bleeding has to be as low as 0.05 ml per minute. But minutest amount of bleeding is picked up. The problem is we will be able to tell you which side the patient, whether it's proximal, small gut, distal small gut is actively bleeding. What is the rate? If it's bleeding relatively rapidly, or is it time for the patient to undergo an angiogram? We have had patients who were referred for GI bleed, where we did study and we thought that it's pretty rapid rate of bleeding, urgently shifted for an angiogram. It turned out to be active bleeder in the duodenum, and it all because of GIST, and it was effectively treated. So, it's a very sensitive test, and if the patient has arrested from bleeding or not, that also you can make out on RBC scan. And in children who are bleeding, we do what is called as a Meckel scan to look for ectopic gastric mucosa. It's a very objective way to diagnose Meckel's diabetes.